This is what we'll talk today. I want to give you a little context. If folks come to the last session we did, it was in December. Some folks weren't here in December, so there's a reason for that. Key knowledge areas that HealthInsight leadership has identified as areas that we think is important for staff to know and understand to do their work. And I'm going to go back, actually. So these are the areas that we identified. If you weren't here in December, the sessions are on eNet. There's an introduction sessions, and they include determinants of health, an introduction to human factors, and an introduction to systems thinking. Today, we're going to take a deeper dive on some of these topics. Around the topic of intervention design, and I'll describe what intervention design means for HealthInsight. There's some particular applications for logic models, and what I think you'll find, even if you're a long-time HealthInsight employee who's been working with us on human factors, I've taken a look at how it applies to one particular aspect of our work. So that's what we have today. So what do we find in what we're talking about, the Key Knowledge Program? Some of what we have to do as professionals, curiously, is unlearn. Our regular experience, our normal experiences includes some things that aren't very helpful. We've learned things that we're going to have to unlearn in order to help healthcare providers move forward. As I said, so unlearning is hard. We're going to work through that. What I want to do today is share ideas that I've found to be useful. I'm not telling you how to do your job. So I've been here at HealthInsight for 21 years now, so no time off for good behavior. And in that time, there's a definition of someone who's an expert, somebody who's made all the mistakes that you can make in a field and paid attention to those. So that's by that definition, I've gained some expertise. So we'll be talking through examples. Let's try to have fun today. With that, we're gonna switch over to the next presentation. So that was our introduction. Now we'll talk about a key knowledge area of designing interventions. A bit of overview of what we'll talk about this morning or today. We'll describe something about what I mean. What are our interventions? There's an important concept related to that that we'll call the performance gap, the use of information and leverage, provider engagement, and learning. So this session's on designing interventions. What are we talking about? Interventions. So here's, and by the way, the next section will be on logic models. This is a simple, basic logic model. Funding, we get dollars come in, and community benefits come out. We're in the middle. The things that we do are interventions. This is, I would claim, not a very useful logic model. Any ideas why? It's not very specific. And not only that, it implies that money can buy happiness. And, that we think isn't true. So this is what we do. We go out, we find ways to get funding to cause or create some benefit in the community. The things that we do, most of them we would describe as interventions. We'll define that a little more specifically and see if it all fits. Let's see. Sometimes, in fact, often, the source of the funding determines the type of benefits that we are charged with making. That is, we're constrained there. We don't get to do whatever we want to in the middle here with our actions. Interventions have a purpose. They advance our organizational mission or ends. They create some future state. There's often explicitly stated aim that is measured. And that can be expressed as an impact and meaning in people's lives. In fact, let's talk about that for just a moment. With all of our activities, everything in that middle box in between the dollars and the benefit, that benefit that comes out can be expressed in terms of how it impacts people. Let's spend a minute on this. This is an exercise that I use in intervention design. One of the measures that we're charged with, one of our teams is working on here at HealthInsight currently, is depression screening in association with primary care visits. Let's spend a minute talking about, and by the way, that's called, with our current contract, does anybody know the letter and the number associated with it? It's G1. G1 is not very inspirational, okay? But it's what we call it. And if we're not careful when we go out and talk to providers, we might call it G1 too. And in that, we lose its real meaning. What is the real meaning for depression screening for people who go to primary care?
Early intervention.
Early intervention, okay. What is that early intervention? Is that, so if I just came back from the doctor's office and I said, they said, what happened at the doctor's office? I would say early intervention. What is the patient? How they express G1?
Sadness.
Okay.
And I feel sick. I feel sicker than other people I know.
Doctor, talk to me about how I was really feeling.
So even if they don't do anything else, just to have somebody acknowledge what you're feeling, talk to you about it, that might be therapeutic, right? And the feeling that depression is not just, a bad day. Depression is it has real impact on people's lives. It has people on people's lives and the people around them. People worry about them. Why don't you go see the doctor? They go see the doctor. And most of the time, they don't get screened for depression, right? They're treated for something else. That's the sort of thing, why do this? I mean, because G1 is not very inspirational. Making a difference in somebody's lives, saying how changing the process of care can change people's experience. That's why we're here. And it's useful to remind ourselves of this for a couple of reasons. One, because otherwise we get caught up in G1. But these projects go on for a long time, as we'll talk about, we work through change agents, and to understand that real impact, I think, is worthwhile. We could do this. We've done this. We don't do it routinely. I think we should. At the beginning of projects, really take the time. Take an hour or two. Talk to people that have experienced this and find out what that experience is like. Okay. So, interventions. So I said we started out with a logic model that wasn't very useful. We're gonna explore some other ideas. Whatever we do at HealthInsight, all those interventions, so like I said, the funding comes in somewhere, the benefit comes out somewhere else. The benefit can be expressed in terms of, and there's no benefit unless it impacts a person, unless there's people at the end of the process. So our impact pathways, the way we work in the system, always ends up impacting people. One thing, so where does change happen? That's interventions are aimed at creating change. At the end of the road, there's always change at the person level. Either they take action to change themselves, we take action to change ourselves, or their care experience or some other experience is different than it would have been otherwise. Those sorts of things are countable. It can be expressed in terms of, well, as we talked about it, expressed in terms of how it impacts their lives, that sort of thing. So, healthcare system. So how does this change occur? Some of it's internal. Some of it we can propose that people could become engaged in self-care behaviors, lifestyle changes. They can make changes on themselves. Some of what happens with the person, the patient, is a result of their interactions with direct care providers. They do something that changes their care practices. They spend the time and resources necessary to redesign their processes. They gain new knowledge, skills, that sort of thing. But something in this interface changes. So how does that happen? Well, these direct care providers work in a larger context. So they work in organizations, they work in facilities, that sort of thing. And those systems have managers, somebody who helps direct resources, set priorities for improvement initiatives, provide leadership. Those folks, in turn, are potentially influenced through other healthcare system stakeholders. There could be, one legislative folks, professional organizations, other consumer groups, that sort of thing, that help set expectations and requirements for system performance, that sort of thing. So these are all different levels of how our system operates. Okay? HealthInsight has the opportunity to act on any one of those levels, right? We have some instances where we interact directly with patients, people. More often, we're further upstream, but not always. Why? Why wouldn't we just go, cut out the middleman? Why start over here? Why don't we just go here every time? What do you think?
For sustainability, it's about the provider-patient relationship.
Okay, so even if we did this, if we're just patching it up, if this whole system remains the same, as soon as we go away, the whole thing's going to fall apart. Right, very good. Other ideas. Why not just go sustainability? Go ahead.
Well, this also, you find out what works and what doesn't.
Okay.
Okay, so you don't repeat the same mistakes.
Okay, very good. How about, here's a problem. There's a lot of these people, and there's a few of us. The further you go up here, you can get to, how many hospitals are there in Nevada?
35.
35, and probably 20 take care of 90% of the patients, right? So if you're looking to influence, say, infections in hospitals, you can work at this level, or you can chase everybody around in every hospital room and make sure they wash their hands, that sort of thing. We don't have the time. So we have to go upstream looking for leverage as well. One other thing, we're not the only people working on this. There are other external environmental drivers operating independently of HealthInsight. They're impacting all of this. Okay, so this is and these types of questions. Where do we seek to express leverage? What type of leverage what do we try to do? Are the choices that we make in intervention designs. Let's see. So let's take a look. The next idea. So this is if you will, a logic model is the different levels of a system, and let's come back to basic intervention design to begin with. There's this idea of a performance gap. So recall from our first not very informative logic model that we have some funding. Somebody's decided that there's something that should be done. And that is driven by typically this idea of a performance gap. So somebody asserts that something is happening to patients that shouldn't, or something that should happen isn't. So if we go back to our depression screening example, the assertion is that screening isn't happening at this level. So, and this is the nature of the gap would be found right here. The care provided is not consistent with the person's needs. Screening for depression should be part of standard care. It doesn't happen. Okay? So, and so what are we going to do about it? The first idea that we bring forward every time is that this idea, the first law of improvement, that every system is perfectly designed to get the results it gets. So if we've got a performance gap, if people aren't being screened for depression in primary care, it's because this system reliably produces that result. We're going to have to take some action to change that somewhere. Okay, so here's our first job in designing an intervention, and that is to understand our performance gap. Okay, so here are the types of questions that I come at this with and spend some time with it. How do we know that this should be changed? What's our evidence that, and I know that, who's working on G1? Is anybody? Nobody in here? Good. Too much expertise would slow us down. So, and this is a brainstorming exercise anyhow, so we don't actually need to know the answers. In fact, it's better that we don't. So let's imagine that was our charge. Depression screening. We've got to increase the reliability of depression screening. How do we know that practice should be changed? Anybody know? Go ahead.
The prevalence is very high in depression in this country compared to other countries.
There's a lot of depression in the United States, right. The U.S. Preventive Services Task Force just recently changed their recommendation to include depression screening upon the assertion that there is plenty of resources for treating depression. Okay. So and yet, by the way, and yet you can find articles where people are concerned about Prozac in the wastewater changing the behavior of fish and shrimp in ways that impact the the ecosystem. So you got to wonder, but it's worth asking. So we need to understand why. Just because we need to know, and because we're going to be talking to somebody here at some point, and we got to be able to communicate with them about that. So we need to become somewhat expert in this. How does it impact patients? Actually, even given the high prevalence of depression, go for a primary care visit, most patients aren't depressed. Now, that's the nature of screening. Most people you screen with a colonoscopy don't have colon cancer, right? But you do it anyhow because of the overall benefit. How do we know that this is not self-correcting? And what do I mean by that? I think this is an interesting prompt. So how do we know this is not self-correcting? Literally, the rule just changed. Within the last year, there's something called the United States Preventive Services Task Force. And their job is to review evidence and make recommendations for what should be included in preventive services. They just upgraded depression screening, like literally it's been within the last year. So the question is, well, isn't the job done? Once they've declared that, won't people start doing that? What's our thinking? Why not?
Providers have to be compensated for the time it takes. Yeah.
Okay. Providers have to be compensated. Okay. What else? Workflow. When is that announcement by a Preventive Service Task Force ever caused a major shift in practice? It's never happened. So it's not going to happen in this case. But it's worth knowing. I mean, this is actually getting at some of the problems we're going to get at. Evidence of the magnitude and importance of the gap. Couple things there. One, and we'll talk a little bit more when we talk about human factors. There's an interesting diagnostic characteristic of the magnitude of the gap. Imagine that we knew that the frequency of depression screening in primary care, what would you think it is? Do you think it's 50% of the time?
No.
Close to zero.
It's close to zero? Okay. I think so. It's probably, you know what, it's probably really practice specific. There's probably some practices that are just, somebody decide, well, we'll put it in the form, we'll do it for everybody, or almost everybody, and there's some practices that haven't. But if you look at the overall, the reason is, if a performance gap is, say, 10% of the time something doesn't happen, then that looks like a reliability gap to me. It looks like they've got it most of the way right, and it's just some errors, errors of omission in this case, some attention problems that are getting in the way of that gap. Now that gap can be really important, right? 10% of the time you want to make sure that you got the right implant, you know, in the operating room 100% of the time. 90% is not good enough for there. But if you're at 10%, 30%, 0%, it's a different character. It helps us understand the problem better. So it's worthwhile knowing what's our performance gap. Any evidence that this gap can be improved. In fact, as we're doing some review on this question, we will find evidence for that. In fact, we might even find, so where are we going to find it? We may be able to have the capacity to do analysis and review patterns of depression screening use in our practices. And guess what? We're always going to find somebody who's figured it out. And those types of bright spots become evidence that the practice can be improved. So it's a useful problem, a useful exploration. Okay. How do we know this isn't really just a symptom of a deeper problem? Here's the thing. That's a trick question. These are always symptoms of deeper problems, but nevertheless, we still gotta, we're always torn by this. So the deeper problem that Leslie pointed out, that maybe our reimbursement system doesn't support this, doesn't support or encourage that. The deeper problem is the reimbursement system. You will almost always find that is the case. And we're going to be torn. We're going to be torn between making improvements today and fixing the foundations. And we'll likely seek a balance between those two. Okay. So from this, and I'm saying review the performance gap. On the front end of a new contract, if you're designing interventions, these sorts of things, this actually goes on over time. But an initial review, it shouldn't take that long. You should be able to get some quick review and statistics, talk to people within a week to start to understand the problem better. Okay, and then reviewing the causes. So now we understand that, okay, so now we've got one review, and now we're going to take a look at the causes. Okay, again, we'll stay on depression screening as an example. What actions would close this gap? So how are we going to know that? We've done a review, we've got some. In fact, oh, sorry, I'll go back a step. Right here, evidence that this can be improved. Some of that evidence we'll be able to find studies, that sort of thing, and some of it we'll be able to find from interviews or talking to local providers. And within that, we should be able to find some examples of how people have actually impacted that problem. So for depression screening, one level this isn't a very difficult problem. Well, at least it doesn't look that difficult from my experience with primary care, right? They give you some forms. We go there, you fill them out. The form for depression screening, the simplest acceptable one, I think, is like two questions, right? So, and when I go to primary care visits, they know how to put a piece of paper in front of me, right? Right? So, you know, is this going to overwhelm them, the idea of one more piece of paper for me? No. So, at that level. But, okay, so I figure that part's not that big a mystery. They must have somebody in my doctor's office who's in charge of putting pieces of paper in front of me, but they haven't done it. So now we got a mystery. They haven't taken that step, or at least in the practices we've recruited, we're going to find out what they've done. Why haven't they done it? This isn't beyond their capabilities, right? We've already established that they can get paper in front of me. Do they not know that this is a problem? It could be, I don't know. I love it when that's the nature of the problem, because it's easy to fix. If they're just not aware of it, and they have the capabilities to do it, then those are great. Acceptance. Do they think that this is the right thing to do? That's a tougher problem, but it's worth knowing. If this is, if you will, a knowledge gap, and this is a I ain't going there gap, and that's a different type. Have they kind of done it in a not very reliable manner? Yeah, so if they look sad, we put that, we put it in the packet, you know, that sort of thing. Or, you know, not reliable. These sorts of things are worth knowing. In fact, what we'll find, because we're not just intervening, say, in depression screening, we're not just intervening with one clinic, right? We're intervening throughout our states. We might find a range of these types of things in different clinics. But it's worth knowing, it's worth asking, especially this problem. And then, and actually, especially problems like what Leslie brought up. Is there some barrier, some real impediment in this, to getting this done? So can we identify contextual factors that promote or inhibit adoption? So for example, you know, are we seeing that some larger clinics are doing this and smaller ones aren't? That sort of thing might be worth exploring. And are there external factors that promote or inhibit adoption? Go ahead.
Could culture be a contextual factor?
Culture is a contextual factor, yes. It was interesting, so I was working on the innovations projects. I was working with a project, and this is sufficiently public information to share it, who was working on, in fact, it was telemedicine with psychiatric care, so counseling, that sort of thing. And their concern was, or what they found, was the practices and their patients were unwilling to engage or unaccustomed to engaging in counseling behaviors. One of the things that they did was talk to the local newspapers and get little articles in there about this new service that was being offered to try to overcome cultural barriers. What else? Oh, so this one, in fact, depression screening has an interesting additional type of barrier, potential barrier that's come up among the causes. What I've been told, what the team has told me, is one of the concerns is not the screening, but when you find somebody, when you're testing somebody positive, that there's a concern that there's not resources, there's not a place to refer people. That's a real concern, and it's worth knowing, because otherwise, we could be beating our heads against the wall, saying, this is so easy, just put the paper in front of them, that sort of thing. And that's not the nature of the problem, or that's not the nature of the barrier. So it's worth it for us to understand what the real barriers are. All right, so after this, so why are we doing all this review? We're headed toward an intervention. An intervention is information. Well, information and a change agent, okay? So our change agent, so recall that in our review, we start sketching out what types of actions are likely to make a difference here. So, and we might identify different actions at different stages, including even at the patient level. And those different actions might be associated with a change agent. That is, someone who can take that action. Somebody who has, if you will, actually I left it off with the means, the motive, and the opportunity to take an action that's going to impact our outcome. Okay? We can't, I don't think, in general, you can specify the change agent if you can't specify the action, if you don't know what you're going to ask them to do. So, but those sorts of things emerge from our review. And what do we do? And then we have to influence the behavior of a change agent, or at least that's a typical way of operating. That is, we're often, a step removed. We're not providing, we're not interacting directly with the person. We're interacting somewhere upstream, and somewhere in this system, somebody's going to take the time and effort to change that system, and that's our change agent. So, what type of information is likely to cause a change agent to take action?
Personal experience. They may know someone who has severe outcome from this. They may personally know it and believe this really needs to change, and I want to do something about it.
Okay. The why. Why is this important? Why are you the one that we're counting on to take action here? Very good. What else?
Money.
Okay, money. Money as a motivator. Okay. Money in terms of viability of a business, future viability, profitability. Okay. Okay.
How about peer pressure?
Everybody else is doing it. Okay. All right. So indeed, that influences behavior and decisions. So.
Competition.
Peer pressure, competition, right?
How about the feeling that you're actually able to make a change?
Tell me more.
That you feel, as a change agent, you have the capacity to do what it takes.
I think you mentioned it earlier, is that, okay, you are a change agent. Okay, you recognize the problem, but, okay, where are we going to go with this? You mentioned resources. You find a problem. Are there resources available to make a change? Just identifying the problem isn't enough.
Right. Okay. Now, by the way, I snuck that one in on you. Most of the time, they don't know they're change agents. We got in fact, many of them, as Jerry was saying, if you will, become inspired by the problem and decide that sometimes some of our most effective change agents would not have thought about themselves in that manner until this particular problem came along and provided them an opportunity to make a difference. It's an interesting, that comes up a lot. Good. Okay, so so we think we can find people who can make a difference, or who didn't even know that they were change agents. And we can find reasons for them to take action. I would add, the only thing, in fact, this is there's two elements, that idea of somebody's capacity to make a change. And we'll explore this a lot. Sometimes people don't take action because they don't think there are effective solutions. Yes, I know that whatever your problem is really important, but it's too big to deal with. I don't, you can work on that I'm not going to die on that hill. And sometimes there are insights, methods that they're unaware of. They'd be happy to do it, but we can identify something that makes that path easier for them, and that can activate them as well. All right. So, and we'll talk about this a lot this morning. Leverage. The idea is where this influences our actions, the actions that we promote, and where we look for change agents, that sort of thing, is how big a difference, how big an effect you get for how much effort, or how many change agents it takes to find them. This graph tries to illustrate an idea that if we have, just because I made it, so I'll show you how clever it is. That in our performance, targeted performance gaps, actually this comes up a lot, so I'll spend a moment on it. So imagine we have whatever it is, our targeted performance gap, and there are a number of failure modes. In fact, this graphic tries to illustrate, this one has 3 primary failure modes, okay? Because this process can produce a performance gap, this process can, this process can. And what this graph tries to illustrate, though, is this project is the money project, or process. This is where most of our failures come from. Occasionally, this guy, 4 steps removed, will create a problem that gets all the way there. But mostly, because it's got the big thick arrow, mostly this is our problem. It's really useful to know when one brainstorms, if one is brainstorming, any one of these failures counts, right? That's the nature of brainstorming. We say, oh, what are all the possible ways that we could produce this bad outcome? Okay? In brainstorming, it's useful to talk about that. But then there's a next step, and there's analysis. It says, okay, those are all the potential ways. Which are the ways that are really killing us? And when it comes right down to, these 2 are what's killing. It's useful. Both levels of analysis are useful. A brainstorming analysis and then a quantitative analysis. What's really, because this is where the leverage is. I could perfect this task, but boy, that's only 5% of my outcomes. So it's not where I'm going to start at any rate. That's how you find leverage. That's a description of that, and we'll come back to that as well. There's one other thing in terms of leverage. There's lots of other things, but one other thing I'll mention right now. Sometimes, it's not uncommon that the same kinds of things that are implicated in the thing that we're targeting have implications for other system goals. Okay, healthcare systems pursue multiple purposes, multiple goals. Improving performance on something here might impact other goals that the healthcare system is pursuing. Why is that useful to know? Remember, These are change agents. We're working through change agents, and they're going to have to promote change in their organization. And they can get more, they may be able to get more energy around it if they can demonstrate that if we do this, we get a bunch of wins and not just the one. Let me give you an example. So we'll come back to the depression screening example. One of the interventions that I expect that we will be working with, welcome, come on in. One of the interventions that I expect we'll be working on is to expand the capacity for primary care providers to provide basic treatment for people with mild depression. It's something that's part of the answer, I'll bet. Okay? Good news. The same types of skills that people develop to provide that basic treatment, I believe, will help them promote behavior change for all kinds of self-care and health engagement behaviors. So it's not just for the depression patients that this skill is useful. And if we're aware of that, then it makes it easier, or at least it makes it more likely that they will invest in developing that skill. So it's useful for us to know as well. Okay. All right, leverage. Action, okay. So this gets to the idea of, so we've identified actions, or at least we talked about identifying them. Who are we looking for in action? So go ahead.
It's feasible and sustainable.
Okay. Feasible and sustainable. And I know you had something, but how would we know?
Others have done it, and they didn't complain about how hard it was.
Okay, so if we can find actual use cases where they've done it, then that's a good signal. Right. Yeah. Did you have? Oh, I'm sorry.
It can be replicated.
Replicated. All right. Okay.
Along those lines, how about scalable to different
Good.
size practices?
Okay. Okay. So generally applicable. Good. So I've told stories about Deborah. I used to tell stories about my daughters. I have a brother who does a little business. He does computer support, and I've taken a computer or two to him throughout the years, and he proposes an action every time that is 100% effective. Well, you need a new one. He tells me. I was like, isn't there something a little? So what? I mean, feasible, sustainable. What's the smallest action I can take that's going to make a difference? Is one of the tests you can apply. It might not be the only action that we consider, but it has that characteristic. We always So let me contrast that. There's always tear it down and build it up. Build a new one. That solution is always available. It's hardly ever practical. So if that's the only one we got, we're in trouble. There's well, I just thought, in terms of leverage, I thought I'd mention this as a intervention or action. Let's see, folks ever heard of iodine deficiency? Jerry has, because you see it very often?
Not now.
Why not?
It's in the salt.
Because it's in table salt. Iodine is in table salt. It costs about 5 cents per person per year. It's the most effective public health intervention ever. And why does it work? Well, it's cheap, right? 5 cents, you don't even know it's adding the cost. What else? You don't have to take any special action. You just snuck it in there. That's the type of action. Boy, if we can come up with interventions like iodine in the salt, those are good good actions. Okay. One other thing we'll talk about all this more. Sustained action. Here's the deal. Our change agents, it's almost never one shot, right? This is for example, for a depression screening, you can expect in a clinic, this is going to roll out over time. They're going to try things. They're going to have to adjust it, that sort of thing. We might be able to create engagement. We recruit them, that sort of thing. You want to do that. We're all enthusiastic about it. But the real key is sustained action. It's not the first action. In fact, and we'll come back to this, the real key might be the way that our change agent deals with setbacks. Because it'll be a rare change agent that doesn't experience any setbacks. All right. So our change agents themselves are intervention designers. What does that mean? Is that we'll have some ideas for them. We'll have ideas of actions that they might take in their organization, and they have to fill in the gaps. Those are general ideas. They get specific. So these same principles, in fact, many of our change agents themselves have to recruit additional change agents. They have to talk other people in the organization into taking action. They have to themselves figure out what the action, how to translate that action into their world. Moreover, and I didn't appreciate this 20 years ago when I started HealthInsight, these people that we interact with, our change agents, they're at some point in their career, most of them will continue in healthcare. The 2 or 3 years we interact with them over a particular topic is just a piece of their career. Their experience with that change initiative may determine how much they contribute for the next 20 years of their career. So we want to make this a positive experience for them with a deeper understanding of their own capacities, abilities, that sort of thing to make a difference in the system. So it's a broad introduction on intervention. These are like I said, these are the types of questions and the types of things that I approach a topic with when I begin. We look at the performance gap, try to understand what information is going to be useful in connecting with change agents, try to exploit leverage, and promote engagement and learning. So what do we leave out? We'll be talking about this in the next section. Logic models are a way we vastly simplified the types of things we're working on here. A way to communicate what we're doing, a way to manage complexity as a team, and a way to find that leverage. So it's one thing to say, iodine in the salt, but somebody else solved that problem for us. The trick for us is to be able to identify that. Human factors, so that we don't become part of the problem. And there's a risk for that in our work, and which we'll talk about also today. And measurement, self-monitoring, and learning. As I said, intervention design for the change agents, it's a continuous process. It's expected to evolve over time. For us, it's continuous as well. That is, we do a lot of review, analysis work on the front end of a project, and then we adjust based on what we find, what the community is telling us as we go. So let's see. That's what we have for a starting point. Questions or comments before we? Okay. So the next sections, we're going to be talking about logic models as a tool for intervention design.